Hello students, welcome back to the series on cardiology lectures. Today in continuation, we will be studying about heart sounds and approach to murmurs. Okay, so let's begin. So every time you describe a heart sound, you speak about the intensity or the loudness and you look at the pitch or the frequency, right? So intensity is what refers to the loudness and the pitch basically refers to the frequency. And we know that the intensity is inversely proportional to the pitch or the frequency. Okay. So based on this, these heart sounds and murmurs can be classified as high pitched and low pitched. Okay. So what are the low pitched sounds? It's easier to remember because the number is few and high pitched are more in number. So you just remember the low pitched sounds as of now. The third heart sound or the S3, the fourth heart sound or the S4. So the S3, S4 and the tumor plop. The tumor plop is a sound that is heard with myxomas. Okay. So the S3, S4 and tumor plop are low pitched sounds. And what is the murmur which is low pitched? We have the MDM murmurs. The MDM murmurs of mitral stenosis and tricuspid stenosis are low pitched murmurs. Okay. So what is the characteristic of all these low pitched sounds? These low pitched sounds are auscultated with the bell of the stethoscope. So these low pitched sounds are auscultated with the help of the bell of the stethoscope. So all the other sounds S1, S2, your ESM murmurs, all of them are high pitched sounds. Okay. So this is the very basic about heart sounds that you have to remember. Now let us look at the cardiac cycle and to understand which sounds occur during which phase of the cardiac cycle. So that helps us in a very easy understanding of the cardiac cycle and the sounds which happen during each phase. So I have a diagrammatic representation of this. So this is how the heart is represented. So we have the RA, RV, the tricuspid valve, pulmonary valves and pulmonary artery, LA, LV and the aorta and the mitral and AV valves. Okay. So we know that the cardiac cycle lasts for around 0.8 seconds. So if you take an average of 70 beats per minute as the average normal heart rate, so per second, what is the cardiac cycle? It is 0.8 seconds. And 0.1 second comprises of the systole and 0.7 seconds comprises of the diastole. Okay. So now just look at the phases and what happens during each sound. So let us look at the first heart sound. So let us look at the first heart sound. So what is the mechanism of the first heart sound? The first heart sound occurs due to the closure of the mitral and tricuspid valve. So closure of the AV valves. Can you see here in this diagram, the mitral and tricuspid valves are closed and this is what results in the first heart sound. So once the mitral and tricuspid valve close, which phase of the cardiac cycle starts? Right? So this marks the beginning of systole. Okay. So this marks the beginning of systole. So the place where the AV valves are closed and the aortic and pulmonary valves are also closed. This is what we call as the isovolumetric contraction. Yes. Followed by the isovolumetric contraction, as you can see here, the valves are open and the blood is flowing out into the aorta and the pulmonary arteries. So the sound which is associated with the opening of the aortic and pulmonary valves is what we call as the clicks. Okay. So the sound which is associated with the opening of the aortic and the pulmonary valves is what we call as the clicks. So clicks are seen following the isovolumetric contraction during the phase of ventricular systole. Okay. Till here clear, you understood what is S1, you understood what is a click. Clicks can be further classified as ejection clicks and non-ejection clicks. We will be looking at it later. Followed by systole. At the end of systole, what will happen? At the end of systole, there is closure of the aortic and pulmonary valves. Correct? So the closure of this aortic and pulmonary valve is what results in your second heart sound, which is nothing but your S2. Okay. So we have the S1, the click and the S2. Okay. Followed by this, there will be a phase of isovolumetric relaxation, which basically means that the aortic and pulmonary valves have closed and the mitral and tricuspid valves have not yet opened. So, there is a phase of isovolumetric relaxation, right. So, this marks the beginning of diastole. This marks the beginning of diastole. The next phase that happens here is that there is opening of the mitral and tricuspid valve. The opening of the mitral and tricuspid valve can result in a sound which is called as the snap, which is called as the opening snap, right. So, can you see that these clicks and snaps are not seen in physiological conditions, they are seen when there are diseases which affect the valves. So, how do you differentiate between a click and snap? So, it is very, very easy now. You know that the clicks happen due to opening of the aortic and pulmonary valves. The snaps happen due to opening of the mitral and tricuspid valve. The clicks are seen in systole, right? So, the snaps are seen in diastole. So, if you hear an extra or an added sound after S2, and if you are thinking it is a click or a snap, it is obviously a snap because it is happening during diastole. Okay, so, this is the basic fundamental difference that you have to know. Fine. Following this, there is movement of blood from the RA to the RV, and this happens during your rapid filling phase. So, this happens during your rapid filling phase, correct. So, the rapid filling of blood, the blood moves from the RA to the RV, this results in your third heart sound. So, let us just have a quick recap. So, S1 is due to the closure of the mitral and tricuspid valve, right, followed by which there is isovolumetric contraction. Then there is opening of the aortic and pulmonary valves. This opening of the aortic and pulmonary valves results in an extra added sound which is known as the click. Followed by that, there can be closure of the aortic and pulmonary valves. This results in your S2. After the closure of the aortic and pulmonary valves, there can be diastole, and after that there can be opening of the mitral and tricuspid valve, and if it is diseased, you can have a sound which is heard which is known as the opening snaps or the snaps. Following that, there is rapid flow of blood from the RA to the RV, and this rapid flow is what results in your S3. Fine. Followed by which there is your diastasis phase, and towards the end of your ventricular diastole, you can see that the atria contracts and pushes whatever amount of little blood left in the atrium to the ventricle, and this is what we call as the atrial kick effect. So, this atrial kick effect results in a sound which is called as the S4. So, that is your fourth heart. Okay. So, if you just remember this diagram and just try and remember what all steps happens there, you can easily identify each heart sound. Fine. So, let us look at each heart sound one by one. So, let us just look at each heart sound one by one. This is your first heart sound. So, the first heart sound, as we know, occurs due to the closure of the mitral as well as the tricuspid valve. Normally, when you auscultate an individual, the mitral and tricuspid valves close almost at the same time with a difference of less than 20 milliseconds. So, in a normal individual, the mitral and tricuspid valves close almost at the same time with a difference of less than 20 milliseconds. So, there are two components, M1 which occurs due to closure of the mitral valve and T1 which occurs due to the closure of the tricuspid valve. Normally, the M1 occurs before the T1, but the difference is less than 20 milliseconds, and hence this split is not well appreciated. So, the split in S1 is not well appreciated. Okay. Now, let us look at the various factors that affect S1. So, the first thing is that valve integrity forms a very important part. So, we know that the mitral and tricuspid valves have to close and they have to coact properly. So, any condition that affects the mitral and tricuspid valves such that they are not able to close properly, then the S1 is going to be soft, correct? So, in conditions where there is some amount of flail leaflet, or if there is an infective endocarditis which is affecting the valve, so the valve is not functioning properly, right? So, there is regurgitation of blood across the valve. So, all of this results in a soft S1. Okay, so the valve integrity plays a very important role in your loudness of S1. Second, let us just look at the Wiggers diagram. The Wiggers diagram is not very complicated. Let us just break it down and understand what is happening. Right, so this is your LA curve and this is your LV curve. Okay, the point where the LV pressure exceeds the LA pressure, the point where the LV pressure exceeds the LA pressure, there will be closure of the mitral valve, right? There will be closure of the mitral valve and this will mark the beginning of systole. Okay, so the point where the LV pressure exceeds the aortic pressure, the point where the LV pressure exceeds the LA pressure, there will be closure of the mitral valve and this will mark the beginning of systole. As you can see here, this is nothing but your normal ECG waveform. It precedes the contraction. It precedes the contraction. So, electrical activity as a dictum precedes the normal mechanical activity. So, only when the impulse arrives and it causes the ion changes, only after that the LV will contract. So, any abnormality with what? With this interval. What interval is this? This is your PR interval. It will affect the intensity of the S1. Yes or no? Right? So, any condition where there is a short PR interval, it will be associated with a loud S1, because if there is a short PR interval, that means that the electrical activity is happening shorter. It happens faster in a state where the mitral valves are quite open and it takes more time at a higher velocity to close. So, there will be a loud S1. Okay. Second factor, position of the valve. Now, let us just look at, this is the LV, this is the LV. Now, your mitral valves are here. So, if the mitral valves are further apart, right, if the mitral valves are further apart, they move with a higher velocity, correct? If they are further apart, it moves with a higher velocity. If there is a higher velocity of closing, what will happen to the intensity of the first heart sound? It will have an increased intensity. Okay. So, which is the condition where this happens? This happens where the LA pressure remains elevated beyond normal. So, if the LA pressure is quite increased, then what happens? The valves close at a higher velocity. So, this is seen in mitral stenosis. So, the only valvular heart disease where you find a loud S1 is your mitral stenosis. Okay. PR interval we have just now discussed. If the PR interval is short, then you will have a loud S1. Okay. So, this can be seen in tachycardia. Any type of tachycardia, supraventricular tachycardias can cause loud S1. Then, timing of closure, this is also what we had just discussed. If the time taken for the valve is more, if the time taken for the valve to close is more, then it results in a loud S1. Okay. If the time taken is early, right, because of the pressure changes, for example, in aortic regurgitation, then the S1 is soft. Okay. So, till here we have understood what are the factors which are affecting S1. Now, let us look at the split. So, split basically refers to the components of S1. S1 comprises of the M1 as well as the T1. In a normal individual, the M1 and T1 split is not appreciated because it is less than 20 milliseconds. What happens in a wide split? In a wide split, it basically means that either M1 happens early or the T1 happens late, correct? So, when do you have an early M1? That basically means that the mitral valve closes early. When will you have an early closure of the mitral valve? When the electrical activity towards the left side of the heart is more, for example, in LV pacing. That means that you put a pacemaker and your LV is contracting faster because it is a paced impulse. So, if it is contracting faster, what does that mean? The PR interval is lesser. If PR interval is lesser, the M1 happens earlier, right? And in Epstein's anomaly, in Epstein's anomaly, there is atrialization of the ventricle, right? So, there is atrialization of the ventricle and the mitral valve is usually not affected. It's the right side of the heart which is more affected, and hence the mitral valve closure happens earlier. Now, let us look at late T1. When the electrical activity to the right side of the heart is delayed because of a right bundle branch block. So, when there is a right bundle branch block, the natural electrical activity will cause the mitral valve to close and the tricuspid valve closes later because of the right bundle branch block. So, right bundle branch block is a cause of late T1. Then we look at tricuspid stenosis. In tricuspid stenosis, what happens? If there is a stenosis at the level of the tricuspid valve, the pressure difference across the valve is much higher, just like how we had seen in mitral stenosis. So, the time taken for the valve closure will be late, right? So, in tricuspid stenosis, the T1 will be late. Okay. Now, let us look at when there is a short split. When there is a short split or a paradoxical split, when the T1 appears before the M1. Okay. So, the T1 appears early in RV pacing, just like how we had explained in LV pacing. If there is an electrical activity that is stimulating the right ventricle to beat faster, the tricuspid valve closes early. And M1 can be late in LBBB and MS. So, very simple. So, if you just understand what are the mechanisms behind which this S1 is happening, then you can understand the split easily. Okay. So, with this we have finished the first heart sound. We have looked at how the first heart sound is formed, what are the factors affecting the valve integrity, position of the valve, how the PR interval, timing of closure of the valves and the split. Now, let us move on to what are clicks. So, we had just revised in the cardiac cycle and how do we identify these clicks? Clicks are systolic sounds, and what are they produced due to? They are due to the opening of the aortic or pulmonary valves, right? So, they are seen during which phase of the cardiac cycle? They are seen during systole. So, they can be classified as ejection clicks and non-ejection clicks. Non-ejection clicks are seen in only one condition, which is your mitral valve prolapse. Ejection clicks can be classified as valvular and vascular ejection clicks. Valvular ejection clicks occurs due to valvular stenosis like aortic stenosis or pulmonary stenosis. Vascular ejection clicks occurs because there is an increased pressure difference, there is an increased pressure gradient. So, this happens in pulmonary hypertension. Okay. So, that's about clicks for you. Now, let us move on to the second heart sound. Now, the second heart sound, we all know second heart sound is due to the closure of the aortic and pulmonary valves. So, the aortic and pulmonary valves in the second heart sound basically comprises of two components. The closure of the aortic valve results in your A2 component, closure of the pulmonary valve results in your P2 component. Now, this timing between the closure of the aortic and pulmonary valve is more than 20 milliseconds. So, in a normal individual, you can definitely appreciate the split, right? So, you can definitely appreciate the split which happens between the split which is basically of the second heart sound, which is your A2 and P2 components. Fine. Now, to understand the second heart sound, there are 2-3 important concepts that you should know clearly. First is your concept of hangout interval. Okay. So, what is this hangout interval? So, hangout interval is basically defined as the time. So, hangout interval is basically defined as the time between the pressure crossovers and the actual closure of valves. Okay, so hangout interval is basically the time which is basically present between the pressure crossover and the actual closure of valves. Let us just understand this with the Vickers diagram itself. Okay, now we know that there should be a pressure crossover. Let us say that this is the LV and this is your LA pressure tracing, right? So there is a point where the LV pressure increases or is greater than the LA pressure. When the LV pressure is more than the LA pressure, this results in the closure of the valves, right? So what is the crossover? The point where the LV pressure crosses the LA pressure, the LV pressure crosses the LA pressure and increases is referred to as the pressure crossover. And the time where the actual closure of valves happen is what is referred to as the valve closure. And this time difference, right? So the pressure crossover happens, but doesn't mean that immediately the valves close. The time difference between that is what we call as the hangout interval. Okay. Why is this concept very important? We will be looking at as we explore the second heart sound further. Fine. So we understood what is hangout interval. Okay. Now let us look at the clinical method. So how do you identify the second heart sound? So in which place is the second heart sound best heard? It is best heard at the base of the heart. So the second heart sound is best heard at the base of the heart. So you comment on the second heart sound in your aortic and pulmonary areas. You don't comment on the second heart sound in your mitral and tricuspid areas. Okay. In the base of the heart with your diaphragm of the stethoscope, you find out the second heart sound. That is your first point. Second point is at the base of the heart, you will have to see the second heart sound during inspiration and expiration. Okay. When do you appreciate the split? Let us understand that concept. Now, this is the reason why you should be knowing about the hangout interval. So, during inspiration, what happens? We all know that the blood flow to the right side of the heart increases, right? So, during inspiration, what happens? We all know that the blood flow to the right side of the heart increases. Now, if the blood flow to the right side of the heart increases, the blood flows from the RA to the RV and it goes to the pulmonary vessels, right? So, there is pooling of blood in the pulmonary vessel, right? So, what does that mean? The pressure or the hangout interval across the pulmonary valves is much higher than that of the aortic valves, right? So, during inspiration, what happens? The aortic valves will close first, correct? So, during inspiration, A2 closes first and followed by the P2. Because the hangout interval across the aortic valve will be lesser because there is pooling of blood in the pulmonary vasculature. So, the pressure difference is more. It takes more time to close. Okay. But the aortic valve is not affected by the inspiratory flow during that time. So, the aortic valve closes first and the P2 happens later. Right. So, the split, normal split, this happens in a normal individual. So, the normal split of A2 and P2 is best heard during inspiration. During expiration, the split is not heard. Okay. So, I hope you have understood till here. Let me just repeat this concept for you. In a normal individual, where do you auscultate for the S2? You auscultate for the S2 in the base of the heart. Then how do you appreciate for the split? When the patient or when the individual is breathing normally, during inspiration you can appreciate the split. Why? Because of the pulmonary hangout interval is higher, so the P2 happens late, whereas the aortic hangout interval is lower, so the A2 closes earlier. So, you get A2 early and P2 after that, and this is A2 P2 or your split, right? During expiration, the split is not heard. So, how do you know whether there is a wide split or a persistent split? So, what is a wide split or a persistent split? So, when the split is heard in inspiration and expiration. So, when the split is heard during inspiration and expiration, that is what we call as a wide split or a persistent split. Okay. How do you know or when do you call it a loud P2 or a loud second pulmonary sound? So, what happens is that normally A2 is louder than P2. In conditions such as pulmonary hypertension, right, in conditions such as pulmonary hypertension, you can have a loud P2. So, in the pulmonary area, when you auscultate, if the P2 is as loud as A2, in the pulmonary area when you auscultate, if the P2 is as loud as the A2, then this is what we call as a loud P2. Okay. So, these are the clinical methods that you employ in your assessment of the second heart sound. Okay. So, till now clear? We have understood what is hangout interval, we have understood how to examine the second heart sound. Now, let us move further and we will see what are the factors affecting the second heart sound. So, your Vickers diagram is back. At this point, we look at the LV and the aortic pressure gradients, right? So, at a point where the LV pressure exceeds the aortic pressure, that is when the aortic valves close, right? So, if the pressure gradient is more, when is the pressure gradient more? In conditions like systemic hypertension, the pressure gradients across the aortic valve is more. In conditions like pulmonary hypertension. So, in systemic hypertension, you can have a loud A2. In pulmonary hypertension, you can have a loud P2. And how do you identify this loud A2 and P2? We have already seen. Then, we also know that the flow and the mobility across the valve also affects the test. Now, let us look at the second heart sound in AS versus AR. What happens to the A2 component in aortic stenosis versus aortic regurgitation? Okay, A2 is soft in aortic stenosis. Always remember that A2 is soft. Don't think that because M1 is loud in mitral stenosis, A2 will be loud in aortic stenosis. No, A2 is soft in aortic stenosis, except in, you always have to remember the exception, except in supravalvular aortic stenosis. Except in supravalvular aortic stenosis. Okay, we will be looking at supravalvular aortic stenosis in the aortic stenosis chapter. Fine. AR, again A2 is soft. A2 is soft in aortic regurgitation as well, except in syphilitic AR. You will have a tambour-like quality because of aortic root dilatation. Right, so you have a tambour-like quality in your syphilitic aortic regurgitation because of aortic root dilatation. Fine? Okay. Now, let us move on to the split in the second heart sound. Let us look at the clinical method, wide split. I have already explained to you, if the A2-P2 split is heard in inspiration and expiration, then this is what we call as the wide split. Alright. Now, when do you get this wide split? That means it can happen when the A2 happens early or the P2 component, which is due to the closure of the pulmonary valves, happen late. So, when will the aortic valves close early, right? When does the A2 happen early? Like I said, if the electrical activity to the left side is more in LV pacing, or if there are ectopics which are affecting the left ventricle, and in mitral regurgitation, you can have an early A2. Late P2 happens when there is a right bundle branch block. Right bundle branch block means the electrical activity to the right side of the heart is reduced. So, then there is a right bundle branch block, or when the pressure difference across the pulmonary valves is more because of a pulmonary stenosis or pulmonary hypertension. The pressure difference is more, it takes more time to close, so the P2 happens late. Okay, so this is why you have a wide split. Okay, where do you get this condition of a wide and fixed split, and what is the fixed term referred to in this wide split? So, fixed basically means that you have this A2-P2 split, right? And you have the A2-P2 split. So, during inspiration also the split is heard, and during expiration also the split is heard. and this is what we call as the wide split. This we know. But what is this fixed term? Fixed basically means that this time between A2P2, remains same during inspiration and expiration. Okay. So this is seen in a condition where there is atrial septal defect. Why? Because both the right side as well as the left side of the heart are equally affected. So there is a wide and a fixed. Fine. So we have understood about the wide split. Now let us look at narrow split. Where do you get a narrow split? The narrow split happens when the A2 becomes late. Right? The A2 comes so late, then the split narrows, and this is seen in severe aortic stenosis because the pressure gradient is more, the A2 becomes late. Okay. Let us look at reverse split or paradoxical split. So what is the clinical method that is used? What is the paradox? The split is appreciated only in expiration. Right? So the split is appreciated only in expiration, and this is what we call as the reverse split. So where do you find that? It's very easy. Again, you just apply the same concept. P2 occurs early because of increased electrical activity. There is RV pacing. Late in severe LVBB, severe aortic stenosis, severe systemic hypertension where the pressure gradient is more, then the A2 occurs much more later. Okay. So that is about the second heart sound for you, right? I hope you have understood everything about the second heart sound. Now let us move on to the third heart sound. So the third heart sound, if you can recollect from your phases of the cardiac cycle, the third heart sound occurs due to rapid filling of blood during diastole, during the rapid filling phase from the atrium to the ventricle, right? So this is why the S3 is heard. So physiologically in young individuals, you can see an S3. In young individuals, you can see an S3. Okay. Pathologically, S3 is seen in heart failure, and it occurs because of increased filling in a non-compliant ventricle, right? So it can be seen in heart failure. So let us understand the clinical method. What do we use for this S3? So S3 can be classified as an LV-S3 and an RV-S3. So how do you differentiate between an LV-S3 and an RV-S3? Left ventricular S3 is best appreciated in the apex. S3 is heard with the bell of the stethoscope because it is a low pitch sound. Okay. RV-S3 is heard in the parasternal area. Okay. So where do you see both this LV-S3 and RV-S3? LV-S3 is seen in left ventricular failure. RV-S3 can be seen in right ventricular failure. Okay. Now when you go through the murmurs, you would have heard of something called as the Carvalho sign, right? So left-sided murmurs increase on expiration and right-sided murmurs increase on inspiration, right? So LV-S3 increases on expiration, RV-S3 increases on inspiration. Okay. So that's about LV versus RV-S3 for you. Now, in mitral stenosis, will you find an S3? No, because you need to have a normal valve for the S3 to happen, right? So in MS it is not seen. In aortic regurgitation, only if the patient is in failure you can see, right? In cases of MR and AS, you can find an S3, right? Because there is increased filling into a non-compliant ventricle. Acute MR, most definitely you can find an S3. Okay? Fine. So that's about your third heart sound. Now let us look at the fourth heart sound. Fourth heart sound is also heard with the bell of the stethoscope. What is the mechanism of the fourth heart sound? It is due to the atrial contraction. There are certain prerequisites for which you need to have for your fourth heart sound to happen. You need to have a healthy atrium, right? The S4 happens only if the atria can contract properly. So in AF, can you have an S4? No, you cannot have an S4. Patient has to be in sinus rhythm. Patient should have a non-stenosed AV valve. So in mitral stenosis, will you have an S4? You will not have an S4. and a non-compliant hypertrophic ventricle is what results in your S4. So, aortic stenosis is a condition where you get your S4 in MS, MR, AR, you don't find an S4. Okay. So, that's about S3, S4 for you. Now, let us look at the various diastolic sounds. The diastolic sounds are, you remember it with this mnemonic, OPT, S3, S4. O stands for opening snap. P stands for pericardial knock. T stands for tumor clot. And then we have your S3 and S4. So, you can see that S3 and S4 are late diastolic sounds, and opening snap, pericardial knock and tumor plop are early diastolic sounds. This tumor plop, S3 and S4 are low pitched, whereas opening snap and pericardial knock are high pitched. Where do you see this pericardial knock? It is a diastolic sound which is heard in constrictive pericarditis. Okay, where do you see this opening snap? We have heard of this before. This is seen in mitral stenosis, right? What is the importance of this opening snap? We know that the S2 happens and then the opening snap happens, and then there is a mid-diastolic murmur which happens because of mitral stenosis, right? So, this gap, what we are seeing here, this is referred to as the A2OS gap. So, the A2OS gap reduces with increasing severity of the stenosis, right? So, opening snap is basically a high pitched murmur which is heard during diastole, and opening snap is heard where? It is best heard in the left parasternal area. Okay. Opening snap helps you to identify the severity of the mitral stenosis because the A2OS gap shortens with increasing severity of the mitral stenosis. Okay. And it's also very important that you differentiate opening snap from your S3. Why? Because the opening snap and S2, S3 can be confused very easily. Opening snap, as I said, is best heard in the left parasternal area. Opening snap does not vary with respiration unlike the S. Okay. So, this brings us to the end of our discussion on heart sounds. Okay. Thank you.